Good morning, everyone. Sorry, we're about to be started. Sorry, we're running a bit behind schedule, but we shall commence with our final set of presentations. In fact, of course, final set relating to a topic that is of great interest to many people, including, or I should say, especially members of the public, because all of these would relate to issues of access. So how do we think about access? How does that relate to governance? These are some of the themes that we'll hopefully pick up from the presentations today. So I'm delighted to start us off this session with presentation by Professor Kaori Muto from the University of Tokyo. As we know, Professor Muto is a medical sociologist. She's done a lot of work in relation to access. She has worked on a number of important, or worked with a number of important committees, including the International Society for Stem Cell Research, as well as WHO's COVID-19 Ethics Working Group. So with this warm welcome, Professor Muto, it's over to you.
Thank you very much for your warm welcome, and thank you very much for, I would like to thank especially Kelvin and everyone at CML for inviting me to this wonderful symposium. And I'd like to thank my colleague, Momoko, and her supervisor in Canada, Jan, for connecting me with Kelvin in my trip to Hong Kong. The stimulating and cutting-edge bioethics discussion we have had for the last few days have been thought-provoking to me, but I'm very encouraged by the friendly atmosphere of this community, which has been cultivated for many years. And so allow me to introduce myself. I'm a medical sociologist and especially in bioethics, and I have conducted quantitative and qualitative study and to foster the public discussions and to provide empirical evidence to public attitude or on public attitude and barriers to policymakers, bioethicists, and legal scholars. And I work as a research ethics consultant at in my institute and also in Japan. And So I have bridged the gap between policymakers, bureaucrats, professionals, and non-professionals, and created an environment where the perspective of people living with particularly serious genetic diseases and severe disabilities are respected. And today I would like to share my experiences, challenges with patient and public engagement in medical innovation. And I have no declaration of my conflict of interest. And I will start by reviewing prominent definitions. The definitions of patient and public involvement in research in the NHS is research that is done with or by the public, not to, about, or for them. And public involvement is also different from public engagement, which is when information and knowledge about research is shared with the public. But in Canada, public engagement in research is described as meaningful and active collaboration in governance, priority setting, conducting research, and knowledge translation. The context of two definitions differ, but the emphasis is on the collaboration between the experts and non-experts. And the democratization of science on the first day, Professor Ho from Taiwan mentioned that she said power sharing. Yeah, and unlike the regulative process of cutting-edge technologies, like discussion like citizens' jury, which was discussed yesterday, PPIE means impacting on research by involving the public in individual research programs. And with regard to terminology, as I am as a non-native English speaker, my observation is that in UK, there is a strict distinction between involvement and engagement. And it appears that involvement is placed at the top of the policy-making process. However, English-speaking countries other than the UK or Canada and the US, the concept of involvement is included within engagement, and engagement appears to be used more frequently. In Australia, both involvement and engagement appear to be used together. And thus, it seems to be very, I think it different in the context of academic discipline, that engagement is used often in the context of the social science, as for example, sociology of science or risk communication and public health. So I have been quite confused about the difference between the two terms. And I cannot decide whether I am incapable of understanding that or the native English speakers don't care about that kind of details, but I'm not sure. But anyway, today I will use the term PPIE. And I would like to introduce the ISPOR, the institute of the famous institute research team conducted a systematic review of more than 180 papers with abstracts and referring to PPIE and sorted out common principles from more than 169 papers that mentioned about the definition. And they found that and proposed a new definition that they say public engagement in research, but the definition proposed by them is the active, meaningful, and collaborative interaction between patients and researchers across all stages of the research processes, and where research decision-making is guided by patients' contributions as partners, recognizing their specific experiences, values, and recognizing their specific experiences, values, and expertise. And so we have to consider the universal and integrated definition of the PPIE. And I read the paper from the Australian government and its MRC, and they clearly stated that the benefits to the public and also benefits to researchers and research institutions. And they say consumer and community involvement in research. And they say clearly stated that the public awareness to the benefits to the public includes research being conducted that is relevant to the community needs, and public awareness or support for science and research, and more effective translation of research to deliver improved health outcomes. And also they emphasize the benefits to researchers and research institutes as well. And especially the important thing is public confidence in research, and also communities being better informed and having greater understanding of research. And turning into Japan, the country does not have the national strategy or guidelines for PPIE. However, in 2019, the Japan Agency for Medical Research and Development, we called AMED, the largest research funding organization in medical R&D, supported by the government, produced a PPIE handbook for researchers, which my research team had drafted. And at that time, the AMED directors decided on the terminology and definitions, and they adopted the original British term PPI. However, they offer the following relatively passive definition. AMED envisions a form of PPI in which researchers draw on insights, advice, and feedback from patients and the public in medical research and clinical processes. And the senior generation of Japanese researchers had strong memories of witness towards patient group and medical trials, and they did not agree with the introduction principles such as partnership and collaboration. However, AMED began educating researchers despite the lack of national strategy and started to introduce a fill-in box on research grant application for describing their PPIE plans. And this change has significantly raised the profile of PPIE among Japanese young researchers, especially. And I believe this was stimulated by the use of fill-in boxes in the application form of UK funding agencies such as Cancer Research UK or other forms by the research ethics committees. However, the promotion of PPIE in a way that motivates Japanese researchers to obtain research funding is accompanied by challenges. The first problem is that the degree to which PPIE is promoted varies by disease and modality. The adoption of some project has been contingent upon the implementation of PPIE. And as a result, PPIE has been actively introduced in cancer, allergic diseases, immunological diseases, HIV/AIDS, schizophrenia, regenerative medicine, and genomic research. And you can guess that these areas are very competitive and funded globally. And another problem is related to Japan's unique policy on rare and interactive disease, which has been in place since 1970s. This policy, which introduces out-of-pocket medical costs and organized government research groups to promote disease legislation and epidemiological study among patients and family with government designated diseases, and has recently enacted in the law. And researchers of rare and interactive diseases want to keep a few patients, a small number of patients and their families in the loop. Likewise, patients and families don't want to let go of the only researchers of these diseases in Japan. And as a result, the two parties are bounded by a strong relationship of trust or co-dependence. The promotion of PPIE, recent promotion of PPIE has placed a heavy burden on the leaders of patient advocacy groups of rare disease who are eager to promote research. In addition, the development of innovative medical technology is concentrated on rare diseases that are difficult to treat with common medicine. For example, many medical creative innovations rush to rare disease. And I got a consultation from the leader of the Patients Association of ALS, the neurological disease. And she said that they were enthusiastically invited to participate in PPIE by researchers in stem cell therapy and gene therapy with whom they had an antagonistic relationship. And we have to consider the risk of patient families being exploited through PPIE. And now I would like to move on to some examples of PPIE that I have implemented. The first example is a clinical trial using iPS cells. And this type of cell is discovered by Dr. Shinya Yamanaka in 2006, and which was expected to play an important role in realized regenerative medicine. The transplantation of iPS-derived retinal cell into very difficult eye disease in 2014 attracted social attention as the world's first in-human trial. The benefits of using iPS cells, the researchers can avoid the use of human embryos, and iPS cells can be easily created from the somatic cells. And furthermore, financial costs may be lower if the cell lines are safely stacked. However, there are risks such as increased tumorigenicity, uncertain cell viability, and excessive social expectation. And there are also ethical concerns such as how to share the benefits with the initial cell donor, as was the case with HeLa cells. And in addition, as discussed yesterday, iPS cells can be differentiated into sperm and eggs. And there is also a special situation in Japan because Dr. Yamanaka has become very, very popular with the Japanese public through his famous charity marathon to get research funding, or as a judge on Japan's most famous music show aired on the New Year's Eve. And he's very talented. His talk is very funny, and so he's so famous. So as a result, there was a great deal of public support for him, and there were concerns that research misconduct similar to what occurred in South Korea during the Fan Usok scandal might happen. And then we planned the dialogues between iPS research team and the patient associations to document concerns and benefits towards research protocols from the first-in-human trials from the patient's perspective before finalizing the research protocol. And why the Research Ethics Committee considered the biggest risks to be the homogeneity of the transferred cells and the failure of successful engraftment, the patient expressed more significant concern about the risks associated with eye surgery. The view was also shared by the physicians, and the patients were also concerned about the financial burden of using accompanying support services and transport costs associated with the hospital visits during the clinical trials. And regarding benefits, patients distanced themselves from social hype, but had confidence in iPS cells. They shared the following comments. For example, in the blind world, you always have to trust other people to make a living. So there is no reason for us to talk about details like whether the cells are good or bad. Or another participant said, it is significant to be free from the current therapies, frequent and expensive injections with less benefits. And another one said, if I can help others with this opportunity, I would like to cooperate even if my clinical trial for safety is uncertain. I was really surprised that most of the participants who were suffering from eye disease said that they were very useless in our society, so that they would like to contribute to our society as a research participants. So it is quite a cynical thing, but they don't have much excessive expectation, but they found their own personal benefits by themselves. And the second example, actually which is not research, is PPRE for the prohibition of genetic discrimination. And this map is the same world map created by GDO that Jan showed on the first day of the conference. And in yellow denotes countries that have not adopted specific laws, regulations, and policies to prevent genetic discrimination, but for which non-binding documents exist. And Japan is yellow. And Japan created the basic principles for human genome research in 2000, based on the UNESCO's declaration on the human genome and human rights. And these principles include a ban on genetic discrimination. However, there is no law prohibiting genetic discrimination in Japan. There are several possible reasons why a law has not been enacted in Japan. First, there is no comprehensive human rights legislation other than the Constitution. And second, there is no stated prohibition on discrimination with penalties, even for discrimination against the disabled, LGBTQ+, and ethnic minorities. And third, the repeal of Eugenic Protection Act was delayed until 1996. And fourth, comprehensive sexuality and human genetic education has been carefully avoided in mandatory education for children. And fifth, the indifference about genetic discrimination by a member of the parliament, and another more, a few more. The lack of the lobbying by genetic researchers to the government, and also the government only embarked on full-scale promotion of genetic medicine since 2017. And people who have been discriminated against have internalized or actually accepted in their inside the stigma and not reported their suffering to society. And for example, in case of genetic counseling, which is common not only in Japan, but also in other Asian countries, clients often talk about their concerns about their marriage and pregnancy. And it is still not easy to people with hereditary diseases to actively share genetic risks with blood relatives, manage their risks proactively, and prepare for clinical trials by joining a registry. Therefore, but we stand up and we collected the signatures from over more than 250 patient, disability, academic, pharmaceutical, and consumer organizations, and lobbied all political parties in Japan, which resulted in the enactment of Promotion of Genomic Medicine Act in June 2023, this year. The act requires the government to draw up a basic plan and implement a policy to promote genomic medicine, as well as response against genetic discrimination and bioethical issues such as genome editing. And since the law does not directly prohibit genetic discrimination, but its enactment does not change the color of Japan and on the world map of GDO. However, since for many years, the Japanese government and member of parliaments have not acknowledged any possibility of genetic discrimination. So I think just the inclusion of the word discrimination in the law is considered a step forward. And within several months, the first basic plan will be drafted based on this act. In the past, when documenting discrimination against people with disabilities and LGBTQs in Japan, there has been a history of collecting a wide range of cases from them, and which were organized by the government panel and used for awareness-raising purposes. So therefore, maybe we have, therefore, together with patients and genetic disorder and their families, we have set up various situations such as employment, insurance, and schools, marriage, and pregnancy. And then we are currently categorizing cases that are acceptable in Japanese society or things that people should stop doing as a matter of etiquette, or unfair discrimination that should be eliminated immediately. And then we finalize the report and publish and submit to the member of parliament next year. And the third example is a very short and recent one, is about the Japanese government's current work on a whole genome sequencing project for cancer and rare diseases. The project will have a data access committee that will make whole genome sequencing data available to academia and pharmaceutical industries. And we have to develop policies to return individual and actionable research results to participants and their relatives, and plan educational activities for capacity building and consider measures to ensure that participants are not disadvantaged and don't experience any discrimination. So as already introduced by Genomics England and all of us research program in the US, this Japanese project also plans to collaborate with the research participants as partners and place them in all decision-making structures. And this is the first, I think, official PPI research project led by the Japanese government. So that's a really good news. And actually, our team and other colleagues who recently work very frequently with the Japanese government to implement the PPIE in this project. But I think it's a good news, and so please wait for a good report in a few years. And in summary, today I have introduced the gradual progress of PPIE for research in Japan and shared the examples of cases which I have been involved. And to respond to rapid medical innovation, it is necessary to promote PPIE in a way that integrates research and care. And it is also necessary to foster readiness for PPIE in as many people as possible to maintain diversity. And it will be necessary to establish evaluation method about the PPI to determine whether PPIE initiatives can be considered meaningful partnerships or not. So thank you very much for your kind attention.
Thank you so much, Professor Muto, for the excellent presentation. We very much look forward to learning more about developments in Japan moving forward. So for our next speaker, we return to Australia. We've had some discussions about Australia developments yesterday. So I'm delighted to have with us Dr. Matilda Haas. She is with Australian Genomics. For some reason, I always think of it as Australia Genomics. I'm not sure if it's Australia. So she's going to, of course, introduce the entire setup. Very keen to, of course, hear her thoughts on some of the discussions we've already had yesterday and then also this morning. So with this very warm welcome, Dr. Haas, the floor is yours.
Okay. All right. So thank you very much, Calvin and organisers, for the opportunity, firstly, even to be here. It's been an absolute pleasure to listen to all the very interesting presentations, but also thank you for the opportunity to be able to speak to you today on behalf of Australian Genomics. I chose this title for my talk because I think, like a lot of other countries in the world, Australia is very enthusiastic about the implementation of novel technologies like genomics in health. But we do have some barriers and challenges to overcome if we're to realise the full benefit of genomics. My hope is that this presentation will highlight some of the challenges that we're experiencing, but also some of the work that we're doing to address those challenges. Okay, so I wanted to begin with an overview of the Australian healthcare system as well. And I know Ainsley did this yesterday. However, I think perhaps supporting our claims that the Australian healthcare system is very complex, my description will probably not overlap with the parts that Ainsley talked about at all. So, as we've said, Australia's health system is highly complex, and it's a mix of different service providers and health professionals who work for a range of different organisations, and they offer primary healthcare services such as general practice, as well as allied health, specialist outpatient services, and hospital services. So the delivery of these health services is the shared responsibility of the Australian government, so the national government, as well as the states and territory governments, of which there are 8, and also local government areas, and also the private sector through private health insurance. Health departments and other agencies are responsible for making health policy and doing service planning. And consumer and advocacy groups also play a really active role in public debates about policies and regulation. The national government also funds medical research, including translational research, most notably through our $19 billion Medical Research Futures Fund, or MRFF. Universities and health services are involved in training health professionals, and voluntary and community organisations provide support both directly to individuals, but they're also involved in things like fundraising for research, as well as awareness raising through public health and advocacy campaigns. So because of this complexity, I suppose the point that I'm getting to is that there are also multiple levels of decision makers. So this is most notably where the health ministers of the 8 states and territories come together with the Australian government's Minister for Health, and they work together to shape Australia's health system. So this can also be a real challenge when resources available in different states and territories are different. And the other issue is that policy made at the national level has to be rolled out or implemented and funded by the states and territories. And so when it comes to the funding aspect of this, I just included this diagram to present quickly because you can see that the complex structure of Australia's health system is reflected by these funding arrangements. So for any given part of the health system, so for example, if you look at the hospitals section in brown there, if you look out to the outer part of the ring, you can see that any of these given parts of the health service are partially funded by Australian government, so national government, as well as state and territory governments having to have a share, and also private funding having a share through private health insurance, and also individuals paying the costs themselves. And so to introduce a novel technology like genomics into this health ecosystem adds even further complexity. This is demonstrated by this rather lovely but highly detailed figure here by implementation scientist Janet Leung of Macquarie University. So here I'll just pick out, some of the parts of this diagram to highlight. But you have issues such as genomic testing having largely been so far funded by research, but delivered in the clinical setting. So that blurs the lines between research and clinical delivery, as well as in areas such as functional genomics testing. We also, if you look to the bottom left, we have challenges in how to safely and securely store and share genomic data. We have the challenge of our health technology assessment system and how consumers can play a role, or consumer groups can play a role in that system. We also need to incorporate public perceptions and attitudes. And we also have to think about how we're going to upskill the workforce to deliver genomics and also for mainstreaming. And so all of this rapid progress in genomics has led to a situation where we've really got policy trying to play catch up. We have had the two top documents in this slide is the National Health Genomics Policy Framework and Implementation Plan. We've had those beginning in 2018, but those documents lapsed in 2021 and they weren't extended partially due to obviously priorities being redirected during the COVID pandemic. So the states and territories are also progressing genomics, but they're doing so at different rates. And they also have, sometimes quite different priorities. And some states have really mature policies, while others are just really in the planning stages at the moment. So different states also have different strengths and weaknesses. And so there's increasing opportunities for leapfrogging and sharing knowledge in this way. One of those opportunities is through the newly established Health Technology and Genomics Collaboration. This has Commonwealth Government as well as state and territory representatives, and these people come together to provide leadership on all issues related to health technology. One of their first tasks is to do a really thorough refresh of this National Health Genomics Policy Framework, and they're working on that now. But the other really big priority of this group is the design of Genomics Australia, which is something I'll come to later in the talk. So I just now wanted to provide a couple of examples of why it's just so important for the states and territories to try to work together to implement novel technologies like genomics, even though they have slightly different regulation, laws and policies. So one example is newborn blood spot screening. So this is really considered a public health success in Australia. More than 99% of babies, or around 300,000 babies per year, are screened for about 30 conditions or so, depending on where the baby's born. This program has been largely unchanged for 30 years or so, but screening is delivered rolled out by the states and territories. And so some states are beginning to introduce new tests for conditions like spinal muscular atrophy and severe combined immunodeficiencies. So because of this, as a part of the 2022 budget, Australian government, committed $39 million to expand the newborn blood spot screening program to include more conditions, but also to ensure the consistency of the program across Australia. Along with this, the Medical Research Futures Fund's Genomics Health Futures Mission, which is a funding granting body, awarded $15 million to 5 different projects so that they could explore the feasibility, effectiveness, health economic, ethical and equity aspects of applying genomics to newborn screening programs. So with such high public confidence and screening rates, we really don't want the introduction of genomics to, stop people or start them to decline testing. From these 5 projects that have been awarded for research funding has come the Genomics Screening Consortium for Australian Newborns. So this was a collaborative that was established firstly to share findings from these 5 projects and to maximise the national policy impact of their findings, but also to decrease the burden on the public and consumer groups who will be consulted as a part of these projects. GenScan is organised into 6 working groups that you can read there in the dot points in the bottom part of the slide. So a second example of where states and territories' consistency is really important when it comes to access to clinical genomic tests is the clinical consent for genomic testing. So this is an Australian genomics-led project that's in its second consideration of the topic. And I think really we've been working on it for about 7 years, and Ainsley has been a part of both of those working groups. So the aim is harmonised, nationally consistent consent materials. Why do we want to do it? Well, we want our consent materials to be aligned with the latest developments and best practice in genomics. So for example, so patients know about things that are coming in like periodic reanalysis of their sequence, or how we might go about contacting at-risk family members. We also want these consent forms to communicate the potentials for data sharing between organisations for clinical purposes, as well as the potential for data sharing for research. And really the ultimate aim is that patients across Australia have a similar experience with genomic testing. So the consent materials include a combined patient and parent guardian consent form for both genetic and genomic tests, and patient fact sheets and health professional guidance. As sort of alluded to, the consent forms cover aspects like data and sample storage and sharing, data reanalysis, patient recontact, withdrawal of consent, and future research. This is, I should say, this has been a really challenging project to progress. And when we've gone out to consultation with the different health departments in the different states and territories, there's been some very specific feedback on issues with the consent forms that have been developed. But we can talk about that more in question time if people are interested. So another issue gaining a lot of traction in Australia at the moment is genetic discrimination in the insurance industry. So recent work shows that because of fears of genetic discrimination, people who are at risk of genetic conditions are choosing not to have testing, and they choose not to be involved in genetic research either. So the quote from Jane Tiller's paper really speaks to this issue. It says, "I continue to be worried for my relatives. It has caused family members to hold off on very important gene testing." So the current situation is that in 2019, the Financial Services Council introduced a moratorium to ban life insurance companies from using individuals' genetic test results to underwrite risk-rated insurance products. However, this moratorium is really not sufficient for at least 3 reasons. The first being that it, as far as I'm aware, is time limited and could expire in 2024. The second is that it is self-regulated by the insurance industry, and there are also quite modest limits to the coverage that can be provided. So according to the A Glimmer study and report that was delivered earlier this year, insurance discrimination and the ban on using these genetic test results needs to be legislated. The A Glimmer report says that recommends that the Disability Discrimination Act is amended to prohibit insurers from using genomic test results at all for risk-rated insurance, and that the Australian Human Rights Commission is engaged to enforce this. And so just in some really recent news, just last week, a consultation was announced by the Australian Government Department of Treasury on the use of genetic testing results in life insurance underwriting. So this consultation is going to be open for 2 months, and it is expected to have a very big influence on the strength of the legislation that's decided upon. It's the view of consumer and advocacy groups that a complete ban on any use of genetic testing is the way to go. So another area where we really must ensure we strive towards equity is with the needs of our people is for our First Nations people. So you're probably aware that Australia's First Nations people are the Aboriginal and Torres Strait Islander peoples. They're the oldest continuing culture on Earth and have existed in Australia for more than 60,000 years. Now they represent around 3% of the population. Australian Aboriginal and Torres Strait Islander people experience extreme disadvantage in many areas, including inequity in health and wellbeing. So there are many initiatives that are Indigenous-led and are arising to help increase both equity of access but improved experience of Aboriginal and Torres Strait Islander people in genetic testing. So, for example, we have the Better Indigenous Genetic Health Services Project and the Integrated Genetic Healthcare Project, which work towards culturally safe genetic services, which includes acknowledging Indigenous knowledges in healthcare. There are initiatives to better reach rural, regional and remote patients, which is where a lot of our First Nations people are living. And groups like NCIG and Align are working really hard towards genetics that can align with the principles of data sovereignty and good data governance and sharing. The Centre for Population Genomics, our DNA study, is increasing the representation of Aboriginal and Torres Strait Islander genomes in reference databases, which is critical for accuracy of genetic test reports. And the last aspect is that it's fairly widely acknowledged that we urgently need to improve HREC or IRB ethics and governance review processes for any research involving Aboriginal and Torres Strait Islander people. So the last example that I was going to talk about was mitochondrial donation, but I think that this was really expertly covered yesterday by Bernadette and other colleagues, and in the discussion. So I think I can probably leave this one. Okay. So lastly, I thought it might be of interest to share that Australia has recently done an inquiry into the approval process for novel technologies. So this was done in the context that, Australia has this desire to be at the forefront of innovation in clinical trials with strong research, development and manufacturing capability in precision medicine. This report was handed down in November 2021 and is called The New Frontier, Delivering Better Health for All Australians. This report, mainly through submissions and evidence heard by the inquiry, identified a lot of challenges in the approval process, which are shown in the grey box there. And really, the purpose of the report was to examine better opportunities for regulatory and health assessment change. And so the report outlined a number of areas where there were really significant issues and came up with a massive number of recommendations, 31 highly detailed recommendations for Australia. So I'll just whip through some of the ones that were quite relevant to our work. So the report indicated that we really need to improve our research and development sector. We need to increase international collaboration and attract more international clinical trials. If we're going to attract international research and clinical trials, we really need to urgently improve our research ethics and governance processes. We need to strengthen teletrials into non-urban areas and develop a national clinical trial register, which also has follow-up outcomes in it. We need to increase our expertise in the amount of health economists that we have in Australia, and we need to improve HTA processes. And part of this is working out how to properly include the patient voice in HTA. And also this needs to be done through better education for not only patients, but clinicians and industry and the public about what health technology assessment actually is. I think I was finished there anyway, but also about improving the newborn screening program, which I've already spoken about. So government is actually meant to respond to these reports within 12 months of their release, and we've waited 2 long years. And just last week, Australian Government Department of Health has finally responded to this report on behalf of whole government. And I haven't had a chance to read through it carefully yet, but I think it looks like government has accepted in part a lot of the recommendations. So we look forward to some, hopefully some forward progress in the coming years. Okay, I just wanted to finish, I think I've probably only got another minute or so. Just wanted to finish really quickly by describing the role of Australian genomics in all of this. So we really have 2 aims. We work towards improving the efficiency and the impact of genomic research that's done in Australia by supporting research projects. And we also work and engage with government to try to drive evidence-based policy related to genomics into practice. And so we do this by working across domains of research and health, data and policy. And we engage globally, mainly through the organisations like GA4GH, as well as locally with the community, public and industry. We have a very strong national network of around 100 organisational partners and 450 individual members. And we're seen really by our stakeholders, and this has come from a stakeholder review process, we're really seen as a critical connector of genomics activity in Australia. As well as supporting other research programs, we also progress our own research. And in our current phase, we are progressing 32 projects that are seen on the slide here in different areas, which address, really key capabilities, resources and policies to support genomic implementation. Finally, we very much welcome the news that genomics implementation would be sustainably funded in Australia with the announcement of Genomics Australia. Now, that's a $28 million investment to get a government entity for genomics. And that's the start of that's been delayed due to the level of consultation that's happening around the design of that. And there is a real significant need to have an ongoing body to oversee this so that we can progress genomics in the key domains of research, data, evidence, practice and community. And so thank you very much for listening. I'm sorry I really pushed to the time limit. Just like to acknowledge everyone who works with us at Australian Genomics, but in particular our lead, Professor Catherine North, and Managing Director Tiffany Bortwood. If you'd like to hear more about what we're doing and become involved, you can subscribe to our newsletter. You can come to our International DNA Dialogue Seminar Series, which happens monthly, and also follow us on social media. Thank you.
Thank you so much, Dr. Haas, for sharing with us these fascinating developments in Australia.
The US healthcare system is a unique tapestry. Thank you. It's a multifaceted landscape woven by the needs of over 330 million individuals, each with their unique healthcare requirements. The US population is diverse, and so are their healthcare needs. This complexity unveils an interconnected web. Providers, payers, and patients intertwine, collectively shaping the narrative of healthcare in the United States. So let's talk about coverage nuances. Here we see the coexistence of public and private dynamics. Government-funded programs and private insurance plans stand side by side, defining the access and inaccess to healthcare services. In 2019, statistics painted a really revealing picture. Approximately 50% of the US population relied on private insurance via employers, while another 20% turned to Medicaid, which is the nation's public health insurance program for people with low income, for children, pregnant women, elderly adults, and people with disabilities, which is jointly funded by the federal government and the states. Another 14% depended on Medicare, which is a federal health insurance for people 65 or older, some younger people with disabilities, and people with end-stage renal disease. So it's a really simple organization, clearly. And still, a concerning 9% of the population remained uninsured, shedding light on the existing gaps in accessibility. And this gap exists because about 10% of the population who is not insured by their employers don't have low enough incomes to qualify for government-funded health insurance, and they're left without coverage. And in this vast system, influential bodies play really crucial roles. Entities such as CMS, the CDC, the NIH, and the FDA are the linchpins in decision-making, shaping policies and enacting regulations that govern our healthcare landscape. These organizations wield substantial influence, guiding the trajectory of healthcare and policies and regulation that impact our entire society. So in summary, the US healthcare system is a complex ecosystem. It's really a tapestry of interconnected elements that are influenced by diverse needs and regulatory bodies. So understanding its intricacies is essential in shaping the future of healthcare. Yeah. So this fragmentation leaves a lot to be desired in our system. It results in unequal and varying coverage depending on ability to pay. Confronting a critical facet of the US healthcare system, it requires a discussion about the roots of inequity that persist within it. The first layer, I really like this slide. So we encounter this universal coverage cap, which is an absence that leaves us without a safety net of universal healthcare. This gap unfortunately widens due to socioeconomic disparities, where income-related barriers limit access and contribute to high rates of uninsurance among certain segments of our population. Now delving into the impact of cost sharing, rising copays have been meticulously analyzed in research, revealing a really distressing trend, which is of reduced healthcare utilization, especially among disparately impacted vulnerable populations. This is a concerning outcome with far-reaching implications for health outcomes and overall well-being. It's really a trickle-down effect. So moving on to financing inequality, we have to examine this really delicate balance between public and private systems. We see this coexistence of government-funded programs and private insurance, each with its share of influence on how healthcare is accessed and delivered. But we can't overlook the harsh truth, which is the system's regressive nature. The fragmented nature of healthcare financing in the US has unveiled this regressive structure that exacerbates existing disparities rather than mitigating them. In essence, the roots of inequity in our healthcare system run really deep. There's lack of universal coverage, socioeconomic disparities, and a financing structure that perpetuates this inequality. So we have to acknowledge that as we navigate these complexities, we must remain committed to acknowledging, addressing, and ultimately uprooting these systemic inequalities. And our collective efforts pave the way for a more just and equitable healthcare system that serves all individuals regardless of background or circumstances. Now here's the iceberg slide that I really enjoy. So transitioning to Point 32 Health's EAG process, beginning with an introduction to Point 32 Health's mission, which is a mission that's rooted in a commitment to equity, which is quite novel, particularly in the US healthcare space. They recognize the existing disparities within healthcare and understand the imperative need for ethical navigation in their pursuits. This slide, which is courtesy of Anita Wagner at Point 32 Health, her contact information is included in these slides. She's wonderful. I like the iceberg slide because it just shows how using a traditional medical ethics approach to address ethical issues in healthcare spheres and insurance spheres is just the tip of the iceberg. There's a more complex and nuanced approach that's needed to really address and remedy these issues. So traditional medical ethics often falls short in addressing the complexities inherent in organizational ethics. First, examining the well-established role of clinical ethics committees. These committees have a long-standing presence within healthcare institutions, and they're primarily composed of clinicians who navigate ethical dilemmas in patient care. Predominantly comprised of clinicians, these committees operate with some mild support from the C-suite. They rely on established codes and precedents following relatively stable processes in their decision-making. Now, contrasting this, let's delve into the organizational ethics committees. These committees are in a developmental phase within organizations. They require the active development of their roles and functions, necessitating wider stakeholder participation beyond just clinicians. Unlike clinical ethics committees, organizational ethics committees require robust C-suite support to thrive and effectively navigate the complexities of ethical decision-making within the broader organizational context. They operate with fewer established codes and precedents, needing to adapt continually as the organization evolves and encounters new ethical and regulatory challenges. So understanding these distinctions is really pivotal as we, in organizations, navigate this intricate terrain of ethical decision-making, and really paying attention to societal ethics, the systems, processes, and policies governing society, and the importance of including perspectives of people who aren't necessarily in the C-suite or employees of the organization or policymakers, but including the perspectives of the consumers who are actually actively impacted by these decisions. So moving on to Point 32 Health's Ethics Advisory Group, EAG process. The EAG's functionality lies in its quarterly deliberations, a consultative and advisory role that plays a pivotal part in Point 32's ethical decision-making processes. The methodology and stakeholder engagement within EAG are paramount. The wide array of participants, including clinicians, consumers, and ethics leaders, ensures a diverse spectrum of perspectives. In these EAG deliberations, Point 32 Health presents real-life case studies following an educational module to illustrate the transparent, consultative nature of the EAG's process. These examples highlight the complexity of decisions faced and the diversity and nuance of the ethical facets of these deliberations. Through illustrative case samples, we can spotlight the EAG's pivotal role in making consumer participation in health insurance deliberations more accessible, thus empowering consumers within a rapidly changing healthcare landscape. By incorporating diverse consumer perspectives and lived experience into the deliberative process, the EAG effectively addresses disparities in healthcare access, striving toward a more inclusive and equitable system that reflects the varied needs and concerns of individuals across different socioeconomic backgrounds and health circumstances. So to really tie this information in with the regulatory governance of emerging health technologies, I've chosen two examples from past EAG deliberations, the first of which is insurance coverage of pre-implantation genetic testing, and the second of which is fertility care considerations for health plans. And the reports from both of these deliberations are linked in my sources slide. I just want to note that Anita Wagner, after these deliberations, takes in all of the notes and the feedback from every single participant and condenses it into a really meaningful report with actions for future actions as well. And as I get into these examples, I want to again emphasize the inclusive nature of these deliberations. They incorporate perspectives from consumers, physicians, insurers, and laypersons, members of the public. These discussions, again, are not only advisory, but open to the public, ensuring transparency and inclusivity in the deliberation process. So insurers, with their understanding of the financial coverage and dynamics, provide critical viewpoints on feasibility and sustainability within the healthcare system. Consumer perspectives, crucial in understanding the needs and experiences of those receiving care, are represented. Physicians, as frontline caregivers, also offer invaluable insights into the clinical implications and patient care aspects. We also, the CEO of Point 32 Health also attends these meetings as well, which is actually something that's quite novel. And additionally, laypersons, representatives of the general public, contribute unique viewpoints, ensuring that the ethical decisions that the insurance company is making resonate with broader societal values and expectations, fostering transparency and inviting broader community engagement in shaping our ethical considerations in the face of emerging technologies. And I find that this is really key and something that's lacking in a lot of places. The EAG's inclusivity ensures a well-rounded and holistic approach to ethical decision-making, reflecting varied perspectives and concerns of stakeholders across the healthcare spectrum, combating issues of inequality and inequity. So here is a summary of the first example, the EAG deliberation on insurance coverage of pre-implantation genetic testing. During these deliberations, the EAG grappled with a myriad of ethical questions ranging from disease to disability and equitable access to cost sharing, institutional obligations, and patient obligations. The EAG contemplated first, which principles should health plan leaders prioritize in their decisions about coverage of pre-implantation genetic testing for mutations linked to hereditary cancers, known as PGTM. This question prompts a careful consideration of ethical principles guiding coverage decisions. Secondly, the EAG asked, what principles should health plan leaders be ready to consider in decisions regarding coverage of pre-implantation genetic testing for diseases like cardiovascular diseases and diabetes in the future, PGTP? This question anticipates the broader ethical landscape, preparing for future deliberations on healthcare coverage. So in these deliberations, polls are delivered to the audience after an educational module that explains some of the more technical concepts to the audience that are related to the deliberation prompt in order to really level the playing field and allow people to participate in an informed manner. So these polls are a result of the following hypothetical posed to EAG deliberants, which I would like to read to you. And this case description is provided courtesy of Jochen Lenners and Ulla Green from the Center for Integrated Diagnostics at Massachusetts General Hospital. The Smiths, Monica and Akeem, a couple in their early 30s, have a family history of breast cancer. Mrs. Smith's mother and aunt were both diagnosed with breast cancer. Mrs. Smith's mother had a tumultuous cancer course, enduring a long and challenging battle with breast cancer. The Smiths have one 6-year-old daughter, Jessica. Witnessing her mother's struggle and the impact it had on their family has instilled deep concerns in the Smiths about the potential hereditary risks of passing on the BRCA1 gene mutation to their children. Following her mother's diagnosis, Monica learned that she carries a specific BRCA1 gene mutation known to be associated with an increased risk of developing breast and ovarian cancer, and that Jessica does not. Concerned about passing on this inherited genetic disease to their future children, the Smiths had abandoned the idea of another child. The Smiths had been closely following the journey of their friends who faced a similar situation and apparently did a test to select healthy embryos. The Smiths learned the procedure is called pre-implantation genetic testing, or PGT. The Smiths sought information about PGT from a genetic counselor and a reproductive endocrinologist. With new hope to expand their family, they were surprised to learn that their health plan would not cover the costs of IVF and PGT to permit selection and implantation of an embryo that would not harbor the genetic mutation. The Smiths joyfully welcomed a second healthy baby girl into their lives. As their second daughter grew older, it became a deeply emotional journey for the Smiths as they were reminded of the absence of Mrs. Smith's mother, who had unfortunately passed away due to the recurrence of her breast cancer. While Monica continues to diligently follow screening recommendations for breast and ovarian cancer screening, the recent loss of her mother further intensified the Smiths' commitment to proactive healthcare. Their concerns were heightened upon hearing recent news about errors in PGT. So they wanted to ensure their daughter's well-being and health and consulted with their healthcare team and decided to have their second daughter undergo genetic testing. And to their dismay, the results of the genetic testing revealed that their second daughter did indeed she did carry the BRCA1 gene mutation. The news came as a complete shock to the family, as they had hoped that by utilizing PGT, they could break the cycle of the mutation within their family. So the Smiths sought guidance from their genetic counselors and healthcare providers, and they were provided with some resources. So with that, these following polls were administered to the EAG, which I'm sure you've had some time to reflect on during the reading of that hypothetical. And the results of these polls really reflect the diverse viewpoints and uncertainties of the lay public regarding the coverage of PGT and IVF, encompassing really complex ethical considerations. But in these EAG deliberations, we're not just answering polls, we're having a really involved conversation and discussion. So amidst these discussions, several reflections from the public emerged. Understanding test accuracy and disease risk emerged as a pivotal consideration for the public. Reproductive rights and justice considerations were prominent, which is particularly notable in the United States following the overturning of Roe versus Wade. The societal implications, notably touching on concerns of eugenics and shared responsibility, weighed heavily in these discussions. And principles outlining health plan decisions were meticulously outlined, forming the ethical framework for future deliberations. So these reflections really offer a glimpse into the depth of ethical complexities that the EAG grapples with, balancing medical advancements, societal impacts and attitudes, and ethical principles in decision-making. So moving on to the next pertinent example, the EAG deliberation on fertility care. In this deliberation, the EAG contemplated, firstly, how should a health plan advance its policies for infertility coverage, considering equity, diversity, and inclusivity? This question really underscores the importance of ethical principles guiding the expansion of coverage to ensure fairness and inclusivity for all members. Secondly, what principles should a health plan consider for funding fertility services outside mandated infertility coverage, balanced with other community well-being services? This question really touches on the delicate balance between funding fertility services while meeting other broader community health needs. And then lastly, how should the health plan transparently communicate its reproductive services coverage? Transparency is really key in communicating with members and ensuring that members are informed about available reproductive services, promoting informed decision-making. So the EAG's deliberations play a crucial role in navigating these ethical dilemmas, ensuring that healthcare products, specifically regarding fertility care, are not only accessible and affordable, but also aligned with ethical principles and societal expectations, and that they're also communicated transparently. So again, here are the poll results from the EAG, the second example, and they really encapsulate the group's sentiments on the imperative nature of equitable fertility care coverage within the health plan, irrespective of state mandates, because there are vastly differing state mandates regarding reproductive care in the US. This overwhelming majority of the EAG supports equal coverage for IVF, reflecting the strong commitment, again, to inclusivity and accessibility in reproductive services. So I find these insights from the EAG to be really invaluable, reinforcing the need for healthcare policies that ensure equitable access to fertility care, that are also aligned with the needs and expectations of diverse members. And again, some more reflections emerged. Inclusivity and equity stood as fundamental pillars guiding ethical decision-making processes concerning fertility care. Goals for equity of covered fertility benefits were also deliberated upon extensively, outlining the necessity of ensuring fair and inclusive coverage for all members. The debate between incremental versus step-by-step change toward equity surfaced, highlighting considerations on the pace and extent of improvements in fertility care coverage. And I found this one really interesting to me because I think a lot of times in policy work, I struggle with wondering whether we should, make small changes step by step or disrupt the entire system. And I think that it's really worthwhile to speak with people who are directly impacted by these systems to kind of understand what their expectations are for change and improvement. Concerns about the business of fertility care were raised, sparking discussions on the ethical considerations regarding financial interests versus patient welfare. And the concept of universality of benefits gained significant attention, contemplating whether fertility care should be universally accessible and covered. And then lastly, the significance of education and advocacy emerged, underlining the need for informed decision-making and advocacy for equitable fertility care. And as I draw this presentation to a close, I'd like to reflect on the role of shaping the future of healthcare and health insurance coverage policies in our current landscape through collaborative ethics and continuous learning, guided by these examples from the Point 32 Health Ethics Advisory Group. Collaborative ethics underscores the importance of partnerships between organizations, policymakers, ethical advisory groups, and the public. It's about fostering collective efforts for holistic solutions that address the intricate ethical challenges and inequities in healthcare. Continuous learning advocates for a harmonious balance between theoretical analyses and practical observations within healthcare organizations. This synergy forms the very foundation of ethical progress, ensuring that our ethical considerations align with real-world scenarios. Through the EAG's contributions in ethical and educational initiatives, consumers have been empowered with essential knowledge, fostering informed decision-making and placing some of the power of healthcare choices back in their hands. Our journey towards a future of ethical healthcare is ongoing, and it's defined by collaboration, learning, and a commitment to empower individuals and improve accessibility for all. So let us expand and continue this collaborative effort, leveraging ethical insights and fostering an environment that prioritizes the opinion, well-being, and equitable access of every individual within our healthcare systems. Thank you so much for your engaged presence.
Thank you so much, Caitlyn. Wonderful presentation. She has wonderfully provided us with a very clear snapshot of a huge body of literature that supports this work. So I'm reminded of the wonderful work done by Caitlyn's colleagues, Professor Nita Wagner that she's mentioned, Professor Dan Wickler, Norman Daniels, James Saban, so all of which contributing to this wonderful body of work. For our next speaker, we are joined by another colleague from PHG Foundation. We've had many very interesting and engaging conversations over the year, actually, yes. So she's going to speak to us about a very important contribution from the PHG Foundation in relation to polygenic scores. PHG has got very instructive materials available from its website. So for those interested, you're very welcome to look them up. Tanya today is going to provide a summary of some of these developments, and which I'm sure will be extremely instructive. So over to you. Welcome, Tanya.
Thank you so much for that introduction, and it's lovely to be here today. So I'm going to be speaking, like Cam said, about the ethical and legal challenges facing the translation of polygenic scores into healthcare. And just to reiterate what my colleague Colin Mitchell said yesterday, the PhD Foundation is a health policy think tank that's a part of the University of Cambridge, and we're focused on how genomics and other emerging technologies can enable better, more personalised healthcare. And we help policymakers understand how new technologies could improve healthcare and the actions that are needed to put innovations into practice. And we produce a broad range of outputs covering lots of different topics. And I popped some of them onto the slide, but they include things like the use of AI, the GDPR and genomic data, and of course, polygenic scores, which is what I'll be speaking about today. So the presentation I'm about to give draws on work from across the polygenic scores work programme at PhD Foundation, and I'm going to provide a quick introduction to polygenic scores for those who aren't familiar with them, outline some possible applications, move on to thinking about some of the ethical and legal challenges that need to be addressed when thinking about governance of these tools, and with a particular focus at the end on the challenge of lack of diverse data. So just to give a bit of introduction, I know some of you will be very familiar with this, and I'm very aware of the fact that lots of you can speak to this slide far better than I can, but I'm going to give it a go anyway. And so for those who are unfamiliar with polygenic scores, this pyramid is often used to depict the role of genetics in disease, and many complex diseases like cancers and heart disease and diabetes are multifactorial and have a genetic component alongside environmental influences. And in some instances, a variant in a single gene has a very marked effect on a person's disease risk, and those lie towards the top of this pyramid, but a large number of individually very low impact variants can together have a significant impact on disease risk. And it might be useful to look at these in combination, and that's known as polygenic risk. I should point out, though, that all diseases are polygenic in the sense that low penetrance variants are likely to play a role in many Mendelian disorders, and conversely, rare variants will have a role in common complex disorders too. But today we'll be focusing on the disorders at the bottom of the pyramid. So what are polygenic scores and what do they tell us? Well, in short, they provide a single measure of the cumulative effect of multiple individually low impact changes. They're also a calculated measure, so you need to develop a statistical model to calculate the score. And so that means that whilst it tells you something about your genetics, it's not a direct measure of genetic change, and it's useful to think about them as a proxy biomarker for genetic predisposition to a trait. An interpretation of a score can be by themselves, or it can be alongside other risk factors as part of a multifactorial risk prediction. So before I go on to explain a bit more about how they can be used, I just wanted to clarify some terminology. Often the term polygenic scores is used non-specifically to refer to all of these things, but we've tried to separate them out in our reports. So a polygenic score model is a statistical model that specifies the SNPs and their weights, and you can create different models for different diseases or for the same disease. And the output is the polygenic score. And we use the term integrated risk model to refer to a multifactorial risk prediction model that may or may not incorporate polygenic score information. And the output of that is the integrated risk score. So how can they be used? Well, essentially, polygenic scores are similar to other risk scores in that they give you information about where you fall on the spectrum of risk. And if you look at the diagram at the bottom of the slide, each circle represents a person, and those with higher scores in the red are more likely to get the disease, and those with lower scores in the yellow are less likely to get the disease. But most people fall somewhere in the middle, and each person's polygenic risk score will be different for each specific disease. Polygenic scores have been developed for a huge number of different conditions and traits. I looked at the polygenic score catalogue this morning, which is an open database of published polygenic scores. And there's currently 3,900 scores published for 619 different traits. And it's hypothesized that some of the best performing ones are cardiovascular disease and in breast, prostate, and colorectal cancer. So, polygenic score analysis can be used for a wide range of healthcare applications, and I'm going to raise just a few of them quite quickly. The first is to inform disease screening programs. So that would be using polygenic scores to stratify individuals into different risk categories and then offer them screening or other interventions on the basis of their risk. And it's generally it was generally proposed that this would be done as part of an integrated risk tool alongside other factors to improve the accuracy of the score and of the prediction. Using polygenic scores in this way is hoped to have a number of benefits, including more accurately targeting screening to those people at higher probability of developing the disease, which could mean that more cases are identified, there's less overdiagnosis, and that resources are better used because you're directing screening towards the people who are most likely to need it. This may also mean that less frequent screening is offered to those at lower risk, and that raises its own set of challenges. The risk-based approach to screening has mostly been discussed in the context of cancer, and there are examples of trials being done looking at polygenic scores for this purpose. So, for example, the Wisdom trial is using polygenic scores and other risk factors to stratify 100,000 women into higher and lower risk groups for breast cancer. Turning to use in people with symptomatic disease, polygenic scores could also be used to refine a diagnosis. An example is when diagnosing a person suspected of having diabetes, a polygenic score could help differentiate between types 1 and type 2. And that's really useful because recommended treatment obviously differs for those two conditions. It could also be used to inform treatment. So this area is not as advanced, but polygenic scores could be used to help predict the likelihood of responding to a particular drug or to inform decisions on treatment options. And there are examples in the disease area of schizophrenia. And a more controversial possible use is using PGS to guide embryo selection. It's more controversial because in conventional monogenic pre-implantation genetic testing, prospective parents are seeking to prevent a single pre-specified severe condition. But polygenic testing screens for common diseases that really range in their severity, and many of them are treatable and preventable. These scores are inherently probabilistic anyway, and it would require parents to have to balance the risks of multiple polygenic conditions when deciding which embryos to implant. So in the UK, it's not permitted, but there is no regulation about which conditions or traits can be screened for in the US, and so it is commercially available there. That said, in 2021, the American College of Medical Genetics and Genomics published a position statement on prenatal testing for multigenic or polygenic disorders, and I've included an excerpt here where they say that they don't think it's appropriate for clinical use yet, and they reiterated this in a 2023 points to consider statement on the clinical application of polygenic scores. So turning to ethical and legal considerations, there's been a lot of thinking about the ethical and legal and social considerations of genetic tests in the context of monogenic disorders, but less so in the context of polygenic testing. And we do need to think about them, given that polygenic scores are already on the market through direct-to-consumer providers, and that large-scale studies investigating the return of polygenic scores have started, studies like Our Future Health. And there are 2 points that I just wanted to raise here. One is that in some ways, polygenic scores raise familiar challenges that are also found in monogenic testing. So, for example, communicating complex genetic information. But in others, it'll differ. So, for example, polygenic scores don't have the same implications for family members as highly penetrant rare variants do. And also just to highlight that the considerations will really differ depending on the application, because in each case, the polygenic score will contribute differently to decision-making, and its impact will be affected by other interventions that are part of the pathway. So, as I just said, the use of polygenic scores raises familiar challenges. When thinking about autonomy, as is the case in clinical genetics, the results of polygenic analysis are intended to empower people, but this is limited by low genomic literacy and uncertainty around results, which can really impact on individual choice. The intention is that these scores will benefit the patient through earlier detection and prevention, but there are many potential harms of genetic testing that are relevant for polygenic scores, and that includes the potential for psychological harm, for false reassurance, overdiagnosis, overtreatment, even stigmatization or genetic discrimination. And then, of course, there are lots of concerns around diversity and equity as well. And I'm just going to share some thoughts on some of these challenges from the perspective of polygenic scores more specifically. So one of the key challenges is that information from polygenic score analysis is neither deterministic nor highly predictive, especially on its own. And so this uncertainty around results combined with low genomic literacy means that it's difficult to communicate, and there's potential for mis or overinterpretation by healthcare providers, by patients and consumers. And that could lead to inappropriate actions like overtreatment or overdiagnosis. Studies have shown us that risk is notoriously difficult to communicate anyway, but with polygenic scores, you have the added concern that people will put more stock in it than they should when they hear the word genetic. And it could mean that people with high risk scores might feel unnecessarily concerned about their result, even when their absolute risk is still small. Or conversely, people with low scores might be less likely to engage with healthcare services if they notice a concerning symptom. And this is a problem because most people who develop a disease will not have a high polygenic score. And this risk of misinterpretation has led the polygenic risk score task force to say that without appropriate communication of the uncertainty around polygenic scores, large-scale deployment could potentially reinforce and amplify false genetic determinism attitudes. And it could also downplay the role of the environment in an individual's health. And so clear and accurate communication of the benefits and limitations around polygenic scores are needed. And it's important that evidence-based guidelines around reporting and feeding back results are developed. There's also a bit of a debate around the role of genetics experts here. So traditionally in the UK, genetic results are returned by genetic counsellors, but those results tend to be more diagnostic in nature, and it's likely that polygenic scores will be used in primary care as part of risk assessments. And so consequently, primary care professionals will need to be able to report back results and discuss their implications. So despite the uncertain clinical value of polygenic scores at the moment, they're increasingly becoming available through direct-to-consumer companies. 23andMe now offer 30 different polygenic score-based reports, including those for type 2 diabetes and coronary artery disease. And one of the challenges around this, as I just said, is that the clinical utility is still disputed. And another is that there's huge industry variation. Services differ in the genetic risks provided, the explanatory information provided, and the cautions that they give over interpretation. And this, again, leaves people at risk of misinterpreting their results and could also have an impact on the health system if people come and approach healthcare services wanting to know the implications of a result that the clinician didn't order, the results of a test that the clinician didn't order. So there's a question around whether it's premature to commercialize polygenic scores for common complex diseases, given the uncertain clinical utility and lack of reporting requirements. Especially when one of the key drivers might be around empowering people with knowledge to change their behaviors. There's a very strong rhetoric of empowerment in direct-to-consumer genetic testing, but research suggests that people don't generally change their behaviors in response to genetic results. And so if we're going to commercialize polygenic scores, then we need appropriate safeguards to be in place that include reporting requirements and advertising standards. So in order to implement polygenic scores into clinical practice, there needs to be evidence that it will be clinically useful and that it meets relevant regulatory requirements. And the key regulations governing the development and deployment of assays and tests are the EU and UK medical device regulations. I should caveat that I am not a medical device expert, but drawing on some of our work at PHG, there are some challenges in applying the regulation to polygenic score analysis. One challenge is that depending on how they are used and the target population and the healthcare pathways involved, each of the steps in the analysis pipeline could be viewed as generating a discrete medical device, or these components could be regarded as a single device with multiple elements that have to be reliable and safe when operated together. And just to illustrate the different components, there are a number of different elements of the pipeline, which include genotyping, the polygenic score analysis, possibly also the integrated risk analysis, and then the digital interface and the mechanisms for feedback. And it isn't clear whether each individual component qualifies as a device or the whole pathway does. And perhaps most importantly, devices need to be shown to be suitable for their intended purpose. And the quote on the screen is an example of the intended purpose requirement. And so it has to be suitable for the purpose and the population that it will be used in. But often polygenic scores research and development is conducted in quite a data-driven way and without a clear intended purpose, which raises challenges in classification and establishing the nature and the level of evidence that's needed to demonstrate safety and efficacy. For example, a polygenic score models might be developed primarily for population screening or applied to a diagnosis or to make treatment decisions, but the evidence of safety and performance required will be different depending on each of these purposes. A really important aspect of polygenic scores in this context is adequately specifying the target population of the device, and failure to do this could lead to devices that perform well in some populations and not in others, and that could lead to bias and inequality. Which leads me on to one of the ethical issues that's received the most attention, which is around the lack of diverse data and the implications for health inequalities. So the data used to develop polygenic scores come from genome-wide association studies, which assess the association between common variants and particular traits. But the majority of findings from these are from populations of European ancestry, which creates a potential source of bias. A key concern about polygenic scores is that they typically transfer poorly to other ancestries. And by that, I mean that a polygenic score model derived from individuals of European ancestry is not likely to be as predictive in individuals of non-European ancestry. And this lower predictive performance in non-European populations could lead to inequalities because the scores are often intended for use in diverse populations that contain mixed ancestry groups. There are, however, several efforts underway to diversify genomic data sets, and that includes the NIH-funded All of Us research program, which aims to recruit more than 45% of its 1 million participants from racial and ethnic minorities. So concerns about the lower predictability of polygenic score models in non-European populations are valid, and we do need more diverse data. But we also need to think more broadly about the product that we're implementing, which is often more than just the statistical model. And as I described earlier, it may also encompass a digital interface, there's a genotyping element, and potentially incorporation of other biomarkers. So to understand the equity issues, we need to broaden outside the PGS statistical model and think about the whole product that we are implementing. So, for example, we need to take into account the fact that in most instances, polygenic scores are likely to be used alongside other biomarkers as part of an integrated risk assessment. And although lower predictability of PGS models are a concern, the effect in real-world settings might be minimized by the limited role that polygenic scores play alongside other risk factors. And so what I mean here is the impact will really be influenced by how much this information contributes to the overall risk assessment. I think another thing that's important to say is that there's a danger in saying, well, if these scores don't work well in non-European populations, then we shouldn't use them in those groups because they don't have any value. And that might not be the case. There's often portability between ancestries. And if individuals are excluded on the basis of factors like ethnicity or crude measures of ancestry, then we might exclude people who could benefit and exacerbate health inequalities. So if we look beyond the genetic data, we see that addressing inequalities is not solely a data problem. This graphic is actually from David Leslie, and it was originally developed to map bias in AI pathways, but I think it applies well in this context as well. The point being that PGS tests have the potential to lead to inequality through different routes. And that includes lack of representative data sets, but also biased design and deployment, the way in which we categorize people, unequal access to healthcare, the feedback mechanisms used. And so diverse data is important, but we also have to take account of the broader societal context that can impact and influence the creation and deployment and use of polygenic scores. So just to conclude, polygenic scores provide additional data that can potentially contribute to decision-making in a variety of healthcare contexts. But in order to promote good governance, we need to consider what polygenic score products are and their intended purpose, because that will guide ethical and regulatory decision-making, and then how those products can be used equitably as part of healthcare pathways. And as I mentioned at the start of this presentation, we have a whole work programme on polygenic scores and have published a variety of outputs, including reports on cardiovascular disease, on clinical utility and validity, on polygenic scores for cancer, and recently a series of short briefings that succinctly cover topics from what are polygenic scores through to regulation and implementation. So those are all freely available on our website. And just a thank you to the brilliant team, many of whom contribute to the polygenic scores work programme, and particular to Salmia Morthy, who leads it. And also thank you to Calvin and Gilberto at CML for having me here today and for your hospitality, and of course the Wing Foundation for their support as well. Thank you.
Thank you so much, Tanya, for the excellent introduction to the wonderful work that PHG has done in this space. Final presentation for the conference, last word. So we have, delighted to welcome back, for that matter, Dr. Barry Sulaiman. Barry, of course, is joining us from Doha, bringing in a very important perspective in working with data through technological capabilities like AI, and how do we think about governance in that space. I think it's very timely to, in a sense, conclude this conference with this particular modality in view. So Barry, welcome back. Barry was with us in our earlier conference on AI, that's in May, and he's going to help us think through some of the issues, hopefully picking up on some of the points that we also considered in May. So thank you so much, Barry.
Thank you so much, Calvin. Yeah, I do have the unenviable task of standing between you all and your flights home. So I'll try and keep it concise. So the perspective I'm bringing in then is to look at AI in precision medicine. Just to give a bit of context, when I was here about 6 months ago, Calvin very kindly invited Glenn Cohen and I to discuss the book that we're publishing next year on health, AI, and the law. And I presented a little bit about that framework that's arisen from the book. Since then, the book comes out next summer. So since then, what I've been turning my attention to is to think about how AI might apply to more bespoke areas or specific areas within health. So, for example, I'll have a piece out this month on regulating the use of AI in psychiatric wards and hospitals. I'm working on one on elder care. And so this is very much I would say, the seeds of thoughts about precision medicine. And so I come not with answers, but with questions. And if there's something that you think you might be able to contribute, that you see some connection with AI and regulation, I'd be pleased to know it, because you're more the experts in this area specifically than I am. I'm trying to find that intersection. So I want to start a little bit by just giving some context. I published a paper. I first presented in Australia last year, and it published recently on a framework that I call AI to Law, which is about explaining the path that we've taken going from the development of new technologies and finally the development all the way through to hard law. And I think that context is important to try and first take a step back before understanding, well, how do we regulate more specifically? So with the emergence of new technology then, well, I say AI is not really new. It's been around since the 30s or 40s, but its use more broadly in healthcare has been more recent. So with the rise with the rise of new technology, we have new problems. So things like explainability, the black box problem of AI, the autonomy of systems, and so on. And and that's the first stage that happens. What typically has happened after that in the healthcare space since 2014 until about 2021 has been lots of articles which examine existing law and try to see how do we adapt existing law to deal with these problems. And a lot of those articles initially focused on tort law and how do we adapt tort law. And it's not limited to torts, though. It goes beyond that. It goes into data protection laws, medical device regulations, and so on. I was just on a panel a few days ago in Taiwan, where a colleague presented on the developments in Malaysia, and his presentation was very much in that second element, which was in Malaysia, we have these laws. None of them specifically apply to AI, but if we think about how we might adapt these laws, this is how they might apply to AI. So we're still in that phase to a large degree. At the same time, what's happened has been the third step has been the development of a soft law stopgap. So we've seen the rise of soft laws guidelines, which we're all quite familiar with, most of them quite useless. Some of them have turned out to be quite useful. I'm developing guidelines myself in Qatar for the use in AI in healthcare research, which is something I'll talk about another time. So from those deliberations and the soft law, we see slowly, all of this is slowly seeped through to hard law. And we see that with the proposed Artificial Intelligence Act, the AILD, the Artificial Intelligence Liability Directive, and the revised Product Liability Directive, specifically coming out of the EU. But actually, those are proposed who've actually beaten them to actually enforce, I would say, hard laws in this space has been number one, Saudi Arabia, who've developed AI-based medical device regulations, which I think are binding based on my early analysis of them. And also the UAE, primarily through Abu Dhabi and Dubai, have developed guidelines which are binding on healthcare entities and institutions for the use of AI. So one has to really keep their eyes peeled for what's going on. But anyway, so that's the framework. And I think this, as I've been here and listened to all these wonderful presentations the last couple of days, I think I see lots of intersections with themes from other talks, the multi-layered governance considerations that Jane Kay, Catherine Littler were talking about. And it led me to think, well, how do we respond to the challenges in the specific subfields, not just generally? How do we respond to the challenges in precision medicine, which has its own facets? Should we develop guidelines that fit within this existing developmental cycle? Is there something else that needs to be done? Do we need bespoke guidance? And I don't know yet what the answer to that is, but it's making me query it. So then let's turn a little bit to what have been some of the uses so far that have been reported in the literature of AI and precision in medicine. And these are just some examples just to get us thinking a bit. There is, in cancer research and treatment, a combination of machine learning and genomics data can assist in the diagnosis of cancer subtypes, helping with the discovery of new markers and drug targets and understanding cancer-driving genes better, which can help contribute to providing customized treatment for patients. Machine learning can be used to diagnose these, not only these subtypes, but they can also be used more generally in disease detection. So if we take the example of autoimmune diseases, normally it takes about 4.5 years to diagnose a serious autoimmune disease. But the combination of AI and big data can help speed up that diagnosis of autoimmune and other health conditions. And tech advances like gene sequencing can help to identify patients at high risk and help to identify changes in certain areas of the genome. And these AI models are trained on large genetic data sets that can provide these insights. And Tanya just spoke about polygenic risk scores, which is it's happening throughout this this conference is people present, things jump out to me. AI and machine learning techniques have been shown to be useful in developing polygenic risk scores that can be used to identify individuals with elevated genetic risks. So when we combine the AI, we can gain insights into genetic predispositions with continuous monitoring to identify early signs of disease. So there's another area. Drug discovery is an obvious one. It's obviously extremely a complex and time-consuming process to develop drugs. It can take decades. But with access to big data and AI, we can identify more promising drug candidates, and these drugs can be tailored to specific patients. So again, if we take cancer as an example, not all cancer drugs are effective for all patients, but genomic databases can help find links between genomic biomarkers and drug sensitivity in cancer. This allows patients to be matched with the most effective treatments. So these are just some examples, and I'm sure there are more out there. Now, if I can take a step back again, that's just looking more precisely precision medicine. Well, then if we take a step back, what are the general legal considerations that we find in the AI space as it pertains to health? And this is information that arises from the book that we're publishing. So of course, there's ethical considerations, but beyond that, if I just can put ethics to one side for now and think about the law, what we've identified is 6 areas, let's say, plus medical device regulation. So those 6 areas being privacy of data, data security, data processing, medical liability, informed consent, and intellectual property. And so one of the exercises I think to contemplate when looking at the application of AI to bespoke areas is, how are we going to see developments in these different areas, and which ones are most relevant to the subfields? So what of these issues are really the most important issues in precision medicine or in psychiatric care, whatever it may be? And I think to answer that requires the people who are looking into those fields in a lot of detail, who know a lot about these issues. But I've extracted some for precision medicine. Before I go to them, I'll just briefly say a little bit about these issues. So of course, with discrimination, algorithmic fairness, and bias, the issue is that the AI systems that are used in medical care are not trained on the appropriate data to the populations that those systems are then applied on. There've already been examples in US hospitals of AI systems being used that were trained on data from patients in one state and then applied on patients in another state, and the recommendations weren't very good because the data that we trained on just weren't matching up. I think privacy raises a whole lot of issues, which I'll speak to in a minute. Security, another one, which there's clear risks, particularly in the precision medicine space, of what happens if data leaks. Medical liability has looked at, well, who's responsible if something goes wrong and a patient is harmed in this space with the use of an AI system. Currently, the position is that the standard of care is the current standard of care applies. AI does not set the standard of care, but the conversation is, well, what happens if AI eventually sets the standard of care? Informed consent. Does a doctor need to tell a patient that they are relying on an AI recommendation for their care? I'm finding different answers in different jurisdictions. The literature in the US suggests that no, a doctor does not need to tell a patient that they're relying on AI for their care. But in Europe, when I read scholarship coming out of Europe, the opposite seems to be being claimed by scholars, saying patients should absolutely be informed. So this is quite unsettled yet, and we're still determining that. I'll speak to in a little bit. Okay, so from these then, I've extracted just some to get us thinking specifically about precision medicine, and that's privacy leading into IP, confidentiality, and informed consent. So on the first, ensuring that AI's decision-making, one key issue is ensuring that AI's decision-making processes are unbiased and ethically sound. This involves making sure that AI doesn't perpetuate existing biases and that it respects patient confidentiality. But to address these concerns, it might be necessary then to disclose how the algorithm actually works. But transparency can be challenging to achieve because of IP concerns generally. And we heard Kathy Liddell's very interesting talk about how there are low levels of disclosure and other issues that arise in this space, which can perhaps be limiting. In the chapter in our book, written by Charlotte Scheider and Cynthia Ho, they talk about how it's going to be really difficult to write laws to address problems in this area. Confidentiality, because genetic information has the inherent potential to link biological material to the individual whom it originated. And because that information is included in biobanks for research purposes and is usually linked to other health data, we have particular issues here. The respect for private life in the case of genetic information requires a careful analysis because this information can relate not only to the individual, but information about their family. So in this regard, individual rights can blend into family rights. So the confidentiality rights, which lie downstream to privacy rights, should also be explained, understood, and respected. So weighing these different values is difficult. And when we incorporate AI into this space, these considerations about confidentiality and the handling of genetic information interact in several ways. One of them is data linkage and re-identification risks. AI's advanced data analysis capabilities increase the risk of re-identifying individuals from supposedly anonymized genetic data, especially when linked with other health data. This challenges notions of privacy and confidentiality. Another issue is that AI feeds into is family privacy rights, because AI can reveal genetic information that pertains not just to the individual, but to their family members. This broadens the scope of privacy considerations, which necessitates clearer communication and clearer consent processes for what the implications for AI might be. And then there are also confidentiality safeguard considerations. So because AI can process and potentially disclose large volumes of sensitive data, we need to think about, well, what are the safeguards that we're putting in place? What do the agreements cover once we're integrating AI? And perhaps I hope, as I'm just flagging these different issues, that there's more that comes to your mind that you can highlight or potentially think of to bring to my mind. Informed consent. Of course, informed consent is a big issue. There are different arguments about consent issues in precision medicine. So, for example, the scope of the original consent regarding secondary uses of samples, the complex issue of authorization or request for sample destruction, the nature of the information to provide to donors, the difficulties in fully guaranteeing genetic sample anonymity, the lack of a clear uniform rules to delimit the extent of property rights. So there's lots of issues in this area. And again, if we think about, well, how does AI's integration affect issues of informed consent? Well, it interacts again in a few different ways. One of them is the complexity of information, because AI algorithms used in precision medicine are incredibly complex. It can make it incredibly difficult for individuals to fully understand what they're actually consenting to where AI is integrated. The nature of information provided to donors becomes more complicated when AI is involved, and it may be difficult to explain how AI processes utilize their genetic data. And I've written it was a book chapter a while ago on explainability in AI, and I think it feeds very much into that. Secondary use of data is another issue. So AI often enables new and unforeseen uses of biological samples and genetic data. And so this raises the question of whether continuous consent, reconsent is practical, or whether broader consent models should be adopted where AI is used. Data anonymity and privacy are other issues. Guaranteeing the anonymity of genetic samples is a big challenge, complicated by AI's ability to analyze vast data sets and potentially re-identify individuals from supposedly anonymous data. This can challenge the traditional assurances of privacy given under informed consent. And then finally, decision-making models. So the debate over whether informed consent should be managed by individuals or delegated to research ethics committees becomes more pertinent with AI, I think, given the complexity and the risks of AI and precision medicine. There might be a push for more expert oversight. These are just some of the issues that came to my mind. I'm sure there's a lot more, and perhaps there's some I've missed there. But then what I've considered then is, well, do we need to create different guidance or specific guidance? Maybe not. This is the open question that I have. And how, and if we do, how does it fit into existing developments? So does it fit into the soft law stopgap where international organizations like the World Health Organization and others have developed these guidelines? Does it fit into that space? Does it fit more granularly into more specific regulatory developments? So there was a tease there in the last talk about medical devices regulations in the polygenic risk score space. So do we need developments and regulations there to account for specific risks that AI is incorporated as another layer, going back to the multi-layered governance issues that we have in this area? If we think about how is the Artificial Intelligence Act actually, what's its premise? Its premise is that, well, in the first instance, if you are bringing a medical device to market, you must comply with the medical device regulations. But then if your device has an artificial intelligence component, you must then, in addition to that, also comply with the Artificial Intelligence Act. So like this layered approach, do we need to factor into that layered approach something for these subfields or not? Or can it be integrated within that? These are just these lingering questions that I have. Or do we need an entirely new bespoke process like the United Arab Emirates, where they're creating specific and new guidelines that haven't existed elsewhere, binding rules that haven't existed elsewhere to account for subfields in this area like this? And these are some of and different countries are taking different approaches. And I've just touched on some of them there, but there's a lot more that one could consider there. What has happened, though, in general across those jurisdictions is that there's been generally some institutions that have been given AI oversight, and there has been quite a focus, I would say, so far on medical device regulations, which might give us a hint of which way things can go. There've been quite a strong focus on the rules of data ownership, but beyond that, there hasn't really been much, I would say, uniformity going on in the paradigms of governance that I've witnessed. So I bring it back to you all then as I conclude. Is there a space where we need to incorporate specific guidance for AI and precision medicine into these efforts? And if so, where do we see them fitting in? And I'll leave it, as I promised, on questions, not answers. And if you would like to continue the talk, if you don't have a question now, please, if we're not already connected, please connect. And I'd love to have those conversations. Thank you so much for listening. Thank you.
Thank you so much, Barry, ending us off with a very important reminder of the task ahead. So we currently, when we think about reproductive technologies and genomics, are dealing with very fragmented regulations and governance mechanisms. So we've got some on genomics, some on reproductive technologies. With the pervasiveness of AI, we've got increasing regulations on AI, basically soft law instruments, but of course, as we see in the EU, with specific legislation on this particular modality, and then of course, data governance. So how are we going to work through all of these complexities? Well, if not, please join me again in thanking Dr. Barry so much for getting us started on this important conversation. Thank you so much, Barry. Well, that brings us to the end of the conference. I'd just like to take this opportunity to again acknowledge the wonderful support that we've received from the Wing Foundation and also from the Hatton Trust in relation to the Wing Hatton Lecture. I'd like to thank all our wonderful speakers. I will be in touch in terms of the next phase of our work. So that's on the edited monograph. But more importantly, I do hope that this is a conversation that we will continue, because there's obviously a lot of developments that will follow. And as we've seen, a lot more work is needed in thinking about how best to address some of these challenges that have surfaced already in our present discussion. Finally, thank you to all our participants. It's wonderful to have you with us. We would love to hear your comments and feedback. Please do feel free to write us. We hope you will also be part of our conversation. So there'll be a lot of developments to follow in terms of the work of this center and also our partners. So whether it's LML, PhD Foundation, and McGill. So this is an arrangement that will continue, and we hope that there will be more partners coming into this consortium, so to speak. So, so do keep in touch. Let me thank you again for your wonderful participation, and have a lovely rest of the day. And for those who are leaving us today or in the coming days, bon voyage. So many thanks again.